Welcome back to the deep dive. We are looking at a set of data today that I think you could really describe as the final word on a nearly decade-long debate.
Oh, definitely.
We're digging into the 9-year outcomes of the CheckMate 238 trial.
This is the big one. I mean, if you follow melanoma research at all, CheckMate 238 has been the benchmark for what we call adjuvant therapy.
Right.
But getting this level of maturity, I mean, 9 years of follow-up, that's incredibly rare. It really moves us from, promising early signals to something more like a definitive historical record.
Exactly. And just to orient everyone,
Yeah.
we are squarely in that adjuvant setting here.
Mm-hmm.
We're talking about patients with stage IB, IE,
Mm-hmm.
or even stage 2 melanoma who have undergone complete surgical resection.
Mm-hmm.
So the tumor is gone, it's in the jar, the margins are clear.
But the risk is still there.
The risk of it coming back is sky high.
Right. And that period, historically, that watch and wait period, was just terrifying for patients and their families. We knew the micrometastases were, likely still floating around. The question was always, what do we blast them with?
And this trial pitted the old heavyweight ipilimumab against the challenger, at the time anyway, Nivolumab.
It's a true head-to-head. Anti-CTLA-4 versus anti-PD-1.
And looking at the source material, the trial design was really rigorous. It was randomized, double-blind, a 1-to-1 ratio.
Yeah.
And no placebo arm here, which I have to assume was an ethical necessity given the risk profile.
Oh, absolutely. By the time this trial was getting started, ipilimumab was already an approved standard of care for adjuvant treatment.
Okay.
So you couldn't ethically give these high-risk patients, sugar water. You had to test the new contender, nivolumab, against the reigning champion.
So let's talk about that matchup because the mechanisms of action are different, and that really dictates the dosing we see in the protocol.
It does. Ipilimumab, the anti-CTLA-4, it works a bit earlier in the immunity cycle. You can think of it as priming the entire immune system in the lymph nodes. It's a bit of a sledgehammer.
Okay.
Nivolumab, the PD-1 inhibitor, works more in what we call the effector phase, out in the peripheral tissues and the tumor microenvironment itself. It's, let's say, a little more precise.
And that difference shows up in the administration.
Yeah.
I was looking at the regimen for the control arm. The ipilimumab group, it's 10 milligrams per kilogram every 3 weeks for 4 doses, and then a maintenance phase every 12 weeks.
Right.
That 10 milligram dose, that's the high dose, isn't it?
It is, yeah. In the metastatic setting, we were often using 3 ml per kg. So using 10 ml per kg in the adjuvant setting was really aiming for maximum efficacy, but, and this is a big but, it came with a very well-known toxicity tax.
Right. Versus the nivolumab arm, 3 milligrams per kilogram every 2 weeks.
Which is, a higher frequency of visits. You're in the chair twice a month, but as we're about to see, the physiologic toll is, well, it's very different.
Okay, let's get into the data. We have 906 patients. We have 9 years on the clock. The primary endpoint is recurrence-free survival, or RFS. And the headline numbers are out, and the spread is, it's substantial.
It's just so consistent with what we saw at year 3 and year 5. But seeing it hold steady at year 9 really validates the biology.
So what are the numbers?
The median RFS for nivolumab was 61.1 months.
5 years.
Over 5 years. Now compare that to ipilimumab, which came in at just 24.2 months.
Wow. So roughly 2 years versus 5 years. I just want to pause there because that gap is enormous.
It is.
We are talking about a statistically significant few weeks or months. We are talking about 3 additional years of disease-free life on the median curve.
It's massive. And even if you look at the tail of the curve, the 9-year landmark, the recurrence-free rates were 44% for nivolumab versus 37% for ipilimumab.
And the hazard ratio is 0.76.
Right, which translates to a 24% reduction in the risk of recurrence or death. In this adjuvant space where you're treating people who are technically cancer-free, maintaining that separation for almost a decade is really the gold standard of proof.
But this is where I get a little skeptical. I'm looking at the next set of charts in the analysis. The overall survival, or OS data.
Okay.
And this looks surprisingly different from the RFS data. In fact, if you just squint a little, the curves are almost touching.
They are very, very close, yes.
Median overall survival was not reached for either group, meaning more than half the people are still alive in both arms, which is fantastic news generally.
That's great news.
But looking at the 9-year survival rate, nivolumab is at 69%, and ipilimumab is at 65%.
Just a 4 percentage point difference.
So play devil's advocate for me here.
Yeah.
If I'm a patient and you tell me drug A keeps my cancer away for 3 years longer than drug B, but in the end I have almost the exact same chance of being alive at year 9, why does it matter? Is nivolumab actually saving lives, or is it just, kicking the can down the road?
And this is the central paradox of so many modern immuno-oncology trials. To understand it, you have to look at what happens after the recurrence. We have to talk about the crossover effect.
The rescue therapy.
Exactly. In the ipilimumab arm, patients recurred much sooner, that median of 24 months. But once they recurred, they didn't just go home, they progressed to the next line of treatment.
Okay.
And what was the standard of care for metastatic disease by then?
It would be an anti-PD-1 agent, Nivolumab or pembrolizumab.
Precisely. The data in the source shows that 44.6% of the ipilimumab patients received subsequent systemic therapy compared to only 37% of the Nivo patients.
So more of them needed more drugs later.
And a huge chunk of those ipilimumab patients got anti-PD-1 therapy after they relapsed.
So the ipilimumab group effectively became a delayed nivolumab group.
You could absolutely frame it that way. The high survival rate in the ipilimumab arm is actually a testament to how good PD-1 inhibitors are at rescuing patients who fail CTLA-4. That tow truck, so to speak, came and picked them up.
Which explains why the overall survival curves merged over time.
Yes.
But that brings us right back to the patient experience, because getting rescued by a tow truck implies you broke down on the side of the highway first.
And that breakdown is not trivial. A recurrence means new tumors. It can mean visceral metastases, liver, lungs, brain. It means more biopsies, more fear, and the physical degradation of having active disease again.
Not to mention the toxicity of the treatments themselves. We touched on the dosing, but let's look at the safety signals in this 9-year report. Ipi is known for being dirty in terms of side effects. Did that play out over the long term?
It really did, and this is crucial for the why-Nivo argument. If survival ends up being similar, the tiebreaker becomes toxicity. Grade 3 or 4 treatment-related adverse events occurred in 46% of the ipilimumab patients.
Almost half the patients had a severe adverse event.
Compare that to 14% in the nivolumab group.
Wow, that is a night and day difference. And we're talking about things like colitis, right?
So colitis is the big one, with high-dose, episevere, life-altering diarrhea that often requires high-dose steroids to manage. Also, hypophysitis inflammation of the pituitary gland, which can leave you hormone-dependent for the rest of your life. Plus the severe rashes.
So going back to my skeptical question, why does it matter if survival is the same?
Right.
The answer is that the ipilimumab patients spent those 9 years dealing with significantly more toxicity from the initial treatment and a much earlier return of the cancer, which then required more aggressive rescue therapy.
Exactly. The nivolumab patients had, on average, 3 extra years of what we call treatment-free survival, or just, healthy survival. They weren't in the hospital. They weren't managing colitis. They weren't getting radiated for a new metastasis.
Which brings up this concept of time toxicity. If you spend your extra years of life sitting in an infusion chair or managing side effects, that's a cost.
It is a huge cost. And the trial data highlights this with the discontinuation rates. A massive number of patients in the ipilimumab arm had to stop treatment early because of unacceptable toxic effects.
The source says treatment was discontinued due to adverse events in 42% of IBI patients.
42%.
Versus only 9% of Nivo patients.
Just think about that. 4 out of every 10 patients on ipilimumab couldn't even finish the planned course of treatment because their bodies couldn't handle it. That alone practically disqualifies it as a preferred standard when you have a cleaner alternative like nivolumab available.
I want to dig a bit deeper into the subgroups. Often in these big trials, you see a drug that works great on average, but then you find out it failed in patients with, say, a BRAF mutation.
Sure.
Or it only worked in PD-L1 positive tumors. Did CheckMate 238 show any cracks in the armor for nivolumab in that sense?
And that's part of the robustness I mentioned earlier. The benefit of nivolumab over ipilimumab was just remarkably consistent across all the key stratification factors. They looked at disease stage, IIB, IAC4 to Nivo1 in all of them.
And BRAF status.
Same story. Whether the patients had the BRAF mutation or were wild type, the hazard ratio clearly favored nivolumab.
What about PD-L1 expression? I know in the metastatic setting, sometimes low PD-L1 expression can make the response less predictable.
In this adjuvant setting, the hazard ratios favored nivolumab regardless of PD-L1 expression levels. Now, the magnitude of the benefit might shift a little bit here and there, but there was no subgroup where ipilimumab suddenly looked like the better choice. It was just a clean sweep.
So it's not a niche drug. It's a broad-spectrum adjuvant solution.
Right. And that consistency is what gives oncologists the confidence to prescribe it without needing to, wait for a dozen different biomarker tests to come back before making a decision.
Okay, let's pivot to the secondary endpoint of distant metastasis-free survival, or DMFS. This feels like the bridge between just recurrence and actual, death. This tracks when the cancer spreads to distant organs.
This is a critical one, and it's specifically for the stage 3 patients in the study. DMFS is a really important surrogate for overall survival because once you have distant Mets, the clock starts ticking much, much faster.
And the data here is striking because they couldn't even calculate the median for nivolumab.
Not yet. Right. At the 9-year mark, more than 50% of the nivolumab patients still had not developed distant metastases. The median is just not reached.
Whereas for ipilimumab, the median was 83.8 months.
Which is, I should say, still impressive. That's roughly 7 years. It shows that ipilimumab is an active drug. It does work.
But not as well.
But nivolumab is clearly superior in preventing that visceral spread. And clinically, that's the whole game. If you can keep the cancer out of the liver, the lungs, and the brain, you are winning.
We talked about the safety profile being better for nivolumab, but are there any late onset surprises? I mean, we are looking at 9 years of data. Did anything weird show up at year 7?
The report explicitly states no new late adverse events were reported. And this is, it's boring news. And in this context, boring is exactly what we want.
Boring is the highest praise in long-term safety data.
It really is. It confirms that the immune-related adverse events, they usually happen while you're on treatment or shortly after. You don't tend to see a patient develop a new autoimmune condition 5 years after stopping a drug. That stability is just crucial for survivorship planning.
Let's zoom out and just look at the sort of economic and logistical implications of this.
Yeah.
We established Nivos every 2 weeks. That's a grind for patients. But the IPI regimen, even though it was every 12 weeks in maintenance, had that 42% dropout rate.
And there's also the financial toxicity of the rescue therapy to consider. Remember, the ipilimumab group required significantly more subsequent systemic therapy.
Right. So even if IPI is cheaper per dose, and I'm not even sure about the current pricing dynamics, the total cost of care for that patient group might be higher.
It almost certainly is.
Because they're relapsing and then needing this really aggressive metastatic treatment sooner.
Exactly. Treating metastatic disease is exponentially more expensive and more resource-intensive than adjuvant maintenance therapy is. By preventing recurrence with nivolumab, you are very likely saving the healthcare system money in the long run, despite the upfront drug costs.
Let's circle back to the overall survival debate one last time. There's been some chatter in the oncology community about whether we rely too heavily on OS as the king of endpoints.
Oh, yeah.
This study seems to be the poster child for why OS might be a lagging indicator.
It is. For decades, the FDA and payers, they looked at OS as the only hard endpoint that mattered. Did they live longer? Simple question. But in an era where we have 5, 6, 7 lines of effective therapy for metastatic disease, OS becomes diluted.
Right.
It reflects the sequence of all the treatments a patient gets, not just the first one you gave them in the adjuvant setting.
So the efficacy of the first drug gets washed out by the success of the rescue drugs.
Precisely. Which is why recurrence-free survival and DMFS are becoming the true measures of an adjuvant drug's worth. Did it do its specific job? Did it prevent the return? CheckMate 238 proves nivolumab does that job significantly better than ipilimumab.
And from a patient perspective, the value of being recurrence-free just cannot be overstated. I imagine the psychological burden of watch and wait is replaced by the psychological burden of anxiety, waiting for those quarterly CT scans.
Absolutely. And if you're on nivolumab, statistically, you are hearing good news, your scans are clear, for 3 years longer on average than if you were on ipilimumab. That is mental health preservation just as much as it is physical health preservation.
So, drawing a line under this study, the authors conclude that the data supports the sustained benefit of nivolumab. Is there any reason, looking at this 9-year data, that a clinician would still reach for ipilimumab in this setting?
In the adjuvant setting, it's very hard to justify. Maybe in a very rare case where a patient has a specific contraindication to PD-1 inhibitors but can tolerate CTLA-4. But that's a pharmacological unicorn. Right.
The toxicity profile of high-dose adjuvant EP is just too prohibitive compared to the efficacy gains you get with Nivo.
So nivolumab is the clear winner, but is it the final winner? Are there newer combos knocking on the door?
Oh, There are always new combos. We are now looking at LG3 inhibitors like relatlimab combined with nivolumab. We're looking at personalized mRNA vaccines in the adjuvant space like the Moderna and Merck trials.
Right.
So nivolumab set the bar incredibly high at 61 months, but the goal is to push that curve up to 100%.
61 months is great, but cured is better.
We're getting closer to using that word. When you see a plateau on the curve at 9 years where nearly half the patients haven't recurred.
For some of them, that might truly be a cure.
It's incredible progress. And I want to leave our listeners with a final thought on these numbers. We look at 0.76 hazard ratios and p-values, but behind every data point in that 44% recurrence-free group is a person who had stage IV melanoma a decade ago and is walking around today cancer-free.
That's the reality of it. 10, 15 years ago, the prognosis for resected stage 4 melanoma was grim. Today, we're debating which drug gives you the best 10-year outlook. That is a massive victory for science.
And a victory for playing the long game. Thanks for breaking down the complexities of the CheckMate 238 trial with me. It's rare we get to see the end of the story quite like this.
A pleasure to review it. It really is a landmark study.
Thanks to everyone for listening. Next time, we'll be diving into something completely different. But until then, stay curious.